Hello and welcome. My name is Michelle Moser. I'm with Revelation Pharma. I'm a clinical liaison in functional medicine, and today we're going to talk about inflammation and chronic pain. Thanks for joining us. Just wanted to go over a couple of points that some of the information that we're going to provide is not necessarily FDA approved, and it's meant as information only and not necessarily for medical advice. Chronic pain in America, according to the CDC, and I'm sure that these numbers have changed because this data is a little bit older. But quite honestly, the prescribing of opiates has increased over 400%, whereas the incidence of chronic pain hasn't really changed. There's got to be a better way to help people with pain, especially because it's noted that over 100 million people in the US live with chronic pain on a daily basis. And there's just got to be a better way. So perhaps we can find a solution together. Of those that are affected with chronic pain, most of them have back issues, but they also will complain of head and neck and even knee pain. And a lot of times this is due to body size or chronic injury, but also gut-related issues as well as hormone imbalance. And we'll talk a lot about all of those issues as we go through this today. So inflammation of the CNS tissues can lead to pain. It can be mild inflammation, it can be major inflammation, it can be localized, it can be systemic. But chronic inflammation is a really big problem, and it can often lead to a wide variety of neuronal dysfunction, injury, and even neuronal death, which we know can lead to other mental health disorders such as dementia and Alzheimer's. Emotional wellness plays a large part with pain. If we're not feeling well, pain tends to be accentuated. If we're feeling wonderful, pain tends to be minimized. But what we know is that chronic pain, even acute pain, can have an overall effect of how we deal with fitness, how we produce at work, how we interact with our family members, and even emotionally, how we tend to go about our day. It's usually led by microglial activation. So the brain matter is made up of mostly microglia. It can also have a pathogenic source. That pathogen may be bacterial, viral, fungal, even protozoal. A wide variety of toxins can also play a role. So whether those are environmental pollutants, heavy metals, even food preservatives. So perhaps someone is having an allergic response to something that they've eaten or taken in somehow. Even traumatic brain injury. So we're seeing a lot of that in the sports arenas, but also in a wide variety of work environments where someone will have a bonk on the head, whether it's due to a major accident or an acute injury. And sometimes that damage that is caused can actually lead to a wide variety of other disseminated issues. We also know that when traumatic brain injury is not successfully dealt with early on, it can lead to other issues later in life that are even more will inhibit health. There's also a lot of autoimmune conditions, some of which actually stem from the health or the dysregulation of the gut. But we also know that as we age, whether it's a chronic stress or hormone imbalance, that aging process can have a dramatic impact on how the neurons actually work in the brain and then send signals throughout the body. And all of this can be a detail of pain. So microglia are the innate immune cells of the central nervous system. They activate in response to neuronal injury. A lot of times acute inflammation in the brain can cause rapid activation of the microglia. It can also change reactive oxidative species. It can make the blood-brain barrier much more permeable to a wide variety of other pathogens. Peripheral immune cells can change. Even metabolic byproduct of the gut can then transverse the gut and then land up in the brain because of the permeability factors being changed. That can all lead to, again, neuronal damage and death, but also a wide variety of behavioral impairments, as well as neurodegenerative conditions. So microglia activation can be caused from a traumatic brain injury, stroke, aging, chronic stress, learning difficulties, seizures, a wide variety of autoimmune disease such as Parkinson's disease, Huntington's, ALS, even autism, a wide variety of psychiatric conditions, as well as, again, autoimmune diseases such as MS and even diabetes. And there's so much more. It just wouldn't fit on this slide. Gut immune connectors explain a lot of the triggers due to even just lack of sleep. If we're not sleeping well, it can cause permeability issues in the gut, where the gut can be much more easily transmission of metabolic byproducts into the systemic bloodstream, which can then permeate the blood-brain barrier. Hormone imbalance plays a large role. Sometimes medications that are used for controlling pain, such as opiates and synthetic opiates, can lead to a wide variety of micronutrient deficiencies, but can also change hormone imbalance. And hormones play a very large role in how we perceive pain and even how we are able to heal from an acute injury. Medications can very much trigger a gut immune connection response, sometimes through a lack of nutrients or even through the changes in diet. Some medications make us queasy or sick to our stomach, and so we lean toward other foods that may not necessarily be as healthy. And the standard American diet is just exactly that, absolutely sad. Because everything we eat and drink plays an important role in inflammation and pain. If our blood glucose goes up, we have more inflammation. Therefore, we're going to perceive pain sooner and longer. The gut produces about 70% of our immune factors and about 90% of the overall serotonin that is produced in the body. Our gut actually makes those medium chain fatty acids that work as fuel for the brain. So if our gut is happy, then we're happier. But the bottom line is the standard American diet is exactly SAD, S-A-D. When we look specifically at what can be enormous triggers, gluten is in so many different food products, whether it's fast food or just part of our everyday diet. Gluten can substitute as a thyroid molecule, but as Dr. Perlmutter puts it in his book, Grain Brain, it can often serve to initiate and potentiate the process of inflammation in autoimmune and neurological disorders. He found that on many occasions that patients' brains changed on MRI just with gluten sensitivity. So they eat gluten and you can actually see the changes on those images. And we've known for a very long time that gluten sensitivity can lead to lesions in the brain and can be confused with diagnoses such as multiple sclerosis. It's really important that we have a healthy gut so that we can even just absorb our everyday nutrients and byproducts from the metabolic processes in our gut. If we have the right biosis, so the correct microbiome, we have enough of the good guys, not so much of the bad guys, and none of the really ugly guys. So we're literally detoxing appropriately from liver metabolites, that we are producing those metabolic byproducts such as propionate and ammonia and sulfates, as well as GABA and other metabolic processes. Those byproducts are really important that they are kept in check and in the right ratios so that we can absorb the nutrients that we need from our foods so that we can have a healthier body. So a lot of times we will rely on supplements, vitamins, minerals, and other supplements to help us have a healthier gut. And a lot of times if those vitamins and nutrients are not supplied in the right ratio or in the right format, we may not be absorbing much at all. So a gerobiome and gerobiotics is literally the understanding of molecular and cellular mechanisms for aging. And it's a newer scientific field of studies of the aging process because the gerobiotics are the probiotics to maintain health and improve quality of life in older populations. And let's face it, the baby boomers are getting older. We're all getting older. So it's really important to focus on this as young as possible so that we can have a greater and healthier, more productive lifespan for as long as possible. When we recognize the biomarkers and potential triggers for improving health span and longevity, that is what is going to make for a happier individual for as long as possible. There is a way to actually test our gut to see what is actually there. By knowing what is there, then we can replace what isn't or correct the imbalance of some of those pathogens or yeast, virus, maybe even change the types of foods or the way we cook our foods so that we can produce those metabolic end products more appropriately. So this is an example of one of the gut tests that are out there. It's made by Microbiome Labs. It's called Biome FX. And you don't have to have Crohn's or ulcerative colitis, SIBO, SIFO. You don't have to have those diagnoses to actually take this test. Some people that have other metabolic disorders, such as diabetes, and we know that diabetes can actually be the source of a wide variety of inflammatory diseases and inflammatory issues, and can also have pain components. But if we're able to maximize the biome and metabolize those carbohydrates and those proteins a little bit more efficiently, then perhaps we can have better blood glucose control and therefore less inflammation and better pain control. When the format of this test result is available, it's usually about a 19, 20, 21 page report. It's all in color. It maps out the microbe species, the pathogens, as well as the metabolites, and the overall picture of the gut. When we can understand the symptoms fully and correlate that back to what is actually happening in the gut, it gives us better specificity to restore the gut to a healthy balance and eliminate some of those root issues. A lot of times that is also the source of a wide variety of autoimmune disease. And by the way, it's a really easy at-home test. It comes with prepaid postage. You literally follow the very easy step-by-step steps, and then go through and complete the test. And the results come back in about 4 to 5 weeks. So micronutrients are very, very important because that is what's actually going to help promote cellular health and mitochondrial health. It can be subtle, it can be acute, it can be silent, and it can be intense. But it can also help us to identify those metabolic workhorses of the body. The bottom line is we know what we know and we don't know what we don't know. So by doing that, we're able to then fully identify what is needed to be replaced. And a lot of times, if we know genetically where we're at, we're able to fully understand why an individual is perceiving pain in a specific way. Perhaps they have a genetic SNP that doesn't allow them to assimilate their vitamins and nutrients. Perhaps there's some medications that they're currently taking that they don't metabolize the proper channels because of genetic changes. So 3x genetics, 3x4 genetics testing is a simple cheek swab, shows you about 36 core insights so that you can really evaluate how to make a full impact on bettering your health from here forward. Anytime that we can manipulate the body to increase blood flow, to allow for better alignment of the central spinal column and allow the nerves to access the body without impingement, we're going to have less pain, less inflammation. If the body is misaligned, sometimes it takes several attempts to actually put it back together because of muscle memory. So whether that is physical therapy, chiropractic, massage, yoga, all of those different attempts can be used even alongside osteopathic medicine, to allow the body to be correctly aligned and again function appropriately and to the best of its abilities. So when we're looking at inflammation and pain, there's a lot of things that we can compound that will meet the unique needs of that individual. And sometimes to correct pain and inflammation, we need to look at hormones. We need to look at some of the core issues that are causing some of these acute or chronic issues. And then we can formulate things as transdermal pain gels and creams. We can use low-dose naltrexone, perhaps ketamine, and even synapsin and oxytocin. With hormone balance, it's very important to take a look at not just estrogen, progesterone, and testosterone, but really a thorough investigation as to what's happening with cortisol, as well as a full thyroid function test, which is TSH, free T3, free T4, TPO, reverse T3, and perhaps thyroglobulin as well. We know that estrogens have antidopaminergic effects and can increase brain-derived neurotropic factor, nerve growth factor. Estrogen is also immune enhancing. Progesterone and melatonin are immune modulatory. So is testosterone being immunosuppressive. And pregnenolone is known as the memory hormone. But what we also know is that low DHEA can be a major risk factor for heart attack and stroke. So it's really important to evaluate what exactly that individual is facing. When we look at salivary testing, which is very easy for the patient to use at home in the privacy of their own home, and they're able to do this multiple times a day, it is a representation of what is actually happening in the cells. And by that, it's a very easy to use, it's easy to comply with and complete this test. Often we will collect a full morning sample, which can look at a wide variety of hormones as well as cortisol. And we can evaluate cortisol morning, afternoon, evening, and bedtime, which gives us 4 points during the day to really look at when those peaks and valleys are to intervene with appropriate therapy. So, for example, if cortisol itself is elevated at bedtime, sleep can often be disturbed. But there's some issues behind that. So, is that person not able to shut things off at night? And so they're actually processing mentally throughout the night. And that can have a dramatic effect on GI. But when someone's not sleeping very well, they also are going to feel pain sooner and for longer periods of time. High cortisol in the bedtime and even in the evening can be due to overeating. High elevated cortisol can also increase weight gain, usually around the middle, can also lead to a wide variety of symptoms that we usually associate with hormone imbalance, such as night sweats and hot flashes. And interrupted sleep is just not going to allow for a productive day throughout the next couple of days. And this is just a view of a few of the saliva tests that are available. Getting a good night's sleep is absolutely critical to decreasing inflammation and pain. It also helps us to regulate our blood glucose levels throughout the day and the evening. Sometimes melatonin can be helpful, and a long-acting melatonin is over the counter, and sometimes that can help us to get to sleep and stay asleep. Magnesium glycinate also helps us to get to sleep. Magnesium maleate will also help reduce inflammation and muscle pain. The glycinate portion of the magnesium can also will cleave off during absorption and can also help soothe the gut. We can also compound a wide variety of drops that can help and enhance sleep. And that is something that is usually by prescription only. To do a deeper dive and take a look at estrogens and how they impact the brain, which can then impact our intensity or our feelings of pain, because only about 4% of all nerves actually reflect pain. So if someone is having pain throughout the day, continually, day after day, perhaps week after week, or even month after month, we can associate that there's probably a lot more inflammation that's going on than what we're actually seeing the body emit in symptoms. Well, we know that estrogen can increase blood flow. It increases glucose and oxygen to the neurons. It helps protect the neurons. It increases neurotransmitters. It keeps the blood-brain barrier working, and it keeps those junctions a little bit tighter. It increases sensitivity to nerve growth factor. It decreases neuronal generation of Alzheimer's beta amyloid peptides and plaques. It's a natural antioxidant, and it increases manual speed and dexterity. It also turns on progesterone receptors. Progesterone in the brain and spinal cord and peripheral nerves usually comes from pregnenolone and is often produced in the ovaries. It can help promote the formation of myelin sheaths, and it can also reduce inflammation throughout the body. Scientists are now looking at progesterone as an alternative for prevention of memory decline, and that's usually in conjunction with balanced estrogens. Progesterone reduces inflammation and pain. It's one of the building blocks of bone. It helps to reduce migraine before menstrual cycles. So usually if someone is having inflammatory response and that is triggering a migraine, and it's usually prior or just prior to their menstrual cycle, that usually means that they have a low progesterone level. Progesterone can enhance libido. It can enhance scalp hair. And it's usually caused by low luteinizing hormone, a lot of stress, because cortisol will bind to the same progesterone receptor, therefore dislodging progesterone from that site. Low progesterone can be caused also from a wide variety of vitamin deficiencies and decreased thyroid hormone and a large intake of sugars. When we look at testosterone, testosterone is available in both the male and female body, as is estrogen and progesterone. They're just in different ratios. Testosterone can increase the sense of emotional well-being, increase muscle mass and strength. It helps with memory. It helps to maintain bone strength and health. It also elevates norepinephrine in the brain. And without enough estrogen, testosterone cannot attach to brain receptors appropriately. When we give testosterone to men, it can help reduce sperm count. So if we're replacing testosterone in men and they are wanting to father a child, we need to be super careful about that. Oral testosterone has been previously associated with an increase of risk of liver cancer. And in men, low testosterone is a huge driver of chronic disease and can also cause neck and back pain. So a lot of times applying testosterone directly to that site can be helpful to reduce inflammation along the spinal column. So let's take a moment and look at another compounded medication, specifically known as low-dose naltrexone. So naltrexone is something in low doses, has low side effects, low risk, low drug interaction profile. It's usually not very expensive, but it does have to be compounded. It's been around for, oh my gosh, at this point, almost 60 years. It was originally patented as a 50 milligram tablet back in 1964. But over the last 40 years, we've learned that there's a wide variety of new issues. And because it is a hormetic drug, meaning that at 50 milligram and above doses, it works very differently than what we see when naltrexone is compounded and used in very low doses, anywhere from ultra low dosing at 1 microgram to very low dosing at 100 micrograms, or low dose anywhere from 0.5 milligram up to 6 milligram. Naltrexone is currently available combined with bupropion for a weight loss product as well. And we know anytime you're going to reduce weight in the body, you're going to decrease inflammation and therefore pain. It's potentially available to treat in low doses over 150 disease states. There are well over, at this point, over 900 published scientific papers and case studies, as well as peer review articles addressing the use of low-dose naltrexone. Some experts estimate that 20% of the population could potentially benefit from using low-dose naltrexone. And during a study in Norway, we actually saw that it was very helpful in controlling the inflammation of the GI tract and minimizing the side effects of Crohn's and ulcerative colitis, and actually helps speed healing of the digestive tract. So a lot of times it was used to instead of other pain medication treatments. But really, how do we start and how do we sort it all out? Well, one of my favorite papers to hand out, especially to providers, is called the Dartmouth paper, what I call the Dartmouth paper. It was published in 2017 by a group of individuals who really wanted to compile the first 900 studies or so, the 900 scientific articles and peer-reviewed articles, so that they could categorize those by disease state. And they summarized each article showing how the study was produced, what doses were used, what were some of the side effects seen, and the successful outcomes that were written about in that paper. It summarizes 85 areas of diseases that relate to neuropathies, fibromyalgia, mental health, chronic pain, chronic regional pain syndrome, as well as multiple sclerosis and a wide variety of other LDN use related diseases. And how it works is it will intermittently bind to opiate receptors, non-specifically. So it will hit the mu kappa and the delta receptor, both in the central nervous system and also in the periphery. At low doses, it will, and only once a day dosing, it will intermittently do that. It will also then increase the production of endorphins, which can then further reduce inflammation. It will also reduce the inflammatory cytokine production. So we've heard a lot about interleukin-6 over the last several years, and it will target interleukin-6, 10, and 12 specifically. It also will bind to the opiate growth factor receptors, which can stimulate healing in the gut. It can actually then reduce that junction size, so you have less metabolites leaving the gut and entering the periphery. And what we have seen is that it also balances the Th1 and the Th2 pathways. So it decreases inflammation through some of the T helper cell regulatory pathways. It functions as an analgesic. It can change respiration, GI motility, reduce inflammation. It will block a lot of toll-like receptors on the cell site, on the cell surface, as well as the TLR9 receptors, which are on the cell surface as well as internal to that cell. Toll-like receptor 9 is specific to a wide variety of itching factors, which some people, when they have very intense pain, can also feel kind of a creepy crawly sensation in their skin. So low dose naltrexone could perhaps control that as well. It will speed healing of the gut and help reduce inflammation throughout the body. So Dr. Bahari, who is a quadruple board certified internal medicine physician, found in 1985, as he was treating AIDS patients, that these individuals were actually getting better, that their T cells were increasing rather than decreasing. And what he found when on further review of those patients is that he was prescribing a 50 milligram tablet, but because most of those individuals were not working at the time, they were actually cutting up their doses so that they could make the medication stretch longer. And so a lot of them were taking as low as 6.25 milligrams all the way up to 12.5 milligrams. And he found that even as little as 5 milligrams of the normal dose had a very different effect and could actually increase endorphin levels by 300%. So it changes the signaling cascade as well. And what he also found is that when you see microglial activation, the toll-like receptor is involved. And if you have blockade of the toll-like receptor, you can actually decrease inflammation, not only in the brain, but throughout the entire body. So he called naltrexone in low dose the glial attenuator. And that is how he went on to describe LDN. So Dr. Bahari was also joined by Dr. Ian Zygon, as well as many others who then went on to write many hundreds of papers on low-dose naltrexone. So originally, Dr. Bahari wrote a protocol to help with a wide variety of inflammatory and pain issues. He would start people at 1.5 milligram. He would then increase them to 3 milligram after a few days, and then further up to 4.5 milligrams. So you'll notice that's a multiple of a 1.5 milligram. But what he found is that it didn't work for a lot of people. So in the last 20 years or so, what we have found is that if we start very low with naltrexone dosing, so perhaps anywhere from 0.1 milligram to 0.5 milligram, and slowly increase that over time. So perhaps increasing by that same start dose every 7 to 14 days, we can actually hone in on what that individual's happy dose is. And that's simply by, as we increase the dose, if they no longer feel as good as they did on the previous dose, we literally move them back down. What we're finding with low-dose naltrexone is that often there are anywhere from 9 to maybe even a dozen dosage changes before we find that individual's happy dose or perfect dose. And sometimes that dose will wear off over time. Sometimes they will not see full manifestation or even greater manifestation of symptom relief until 4 to 6 months down the road. It just really depends on the individual, and it really depends on what exactly it is we're trying to control. Whether we are looking at autoimmune disease that is then causing the inflammation and pain, or if we're looking at an acute inflammatory response due to injury, we literally treat those very differently. We do see upregulation of endogenous levels of endorphin, metacaphalin, and the opiate growth factor that concomitantly, respectively, increases the mu, delta, and kappa opioid receptor expression. So again, this is how we're going to use low-dose naltrexone. So it literally doesn't cure anything, but what it does is it forces the body, reminds the body, work on your natural pathways. And it literally, if we stop low-dose naltrexone, all of that goes away. So it has a half-life of about 4 to 6 hours in the body. So when we're using the medication specifically for chronic pain, and this protocol comes to us courtesy of the Norman Marcus Pain Institute. So Dr. Norman Marcus was very kind to allow us to put this, share his protocol with you all today. So he uses very low dose, so literally 100 micrograms as a starting dose, 0.1 milligram. And every 2 days, he will increase and add an additional dose so that by around the 9th day, he is now increasing the dose as well as the number of times a day that it's used. But what he also notes is that a lot of times when we're dealing with muscle pain in conjunction with joint and other inflammatory issues, that a lot of times there is a higher histamine release because of what's actually happening on the muscle fiber. So a lot of times he will use histamine 1 and histamine 2 receptor antagonists, such as diphenhydramine or famotidine, and sometimes even leukotrienes to then sensitize the tissues so that better control of pain is found. What he also notes is that if after a dose increase and it's been 2 days, if someone is not feeling as good as they did on the previous dose, or they're not feeling any change whatsoever, he literally reduces them back and puts them back down at the lower dose. Again, less is more. So with low-dose naltrexone, very low-dose naltrexone, or even ultra-low dose, which was the Oxytrex study that was put together back around 2007, and that was using 1 microgram of naltrexone combined with 5 milligrams of oxycodone. And they found that the 1 microgram of naltrexone not only helped produce more analgesic effects of the oxycodone, but for longer periods of time. And what they were able to do then is actually decrease the amount of oxytocin being used, oxycodone being used, and then substituted that with more low dose naltrexone or even ultra low dose naltrexone. So we can literally help move people off of opiates and onto low dose naltrexone by using ultra low dose dosing protocols. It's very, very fascinating. And this is, by the way, a look at the Dartmouth paper, and it does go over the mechanism of action of LDN, very low dose naltrexone, and ultra low dose associated with a wide variety of medical diagnoses. So when we compound low dose naltrexone, very low dose or ultra low dose, we're often using a wide variety of protocols, but also dosage forms, because again, we're trying to meet the needs of the individual in front of us. And we realize that not everyone is going to be the same. So sometimes we have to be careful if we're making capsules, we've got to be careful of fillers, same thing with tablets. But we also have to be careful of sublingual dosage forms or oral dosage forms that are in liquid form. Sometimes liquids are a water base, so they're not going to have a very long beyond use date, perhaps 35 days or so. But if we're using an oil form of a sublingual or oral dosage liquid base, we can have a longer beyond use date, perhaps 90 days. Naltrexone by itself is really bitter, so we often will use medications and products to actually block the bitterness, and also mild sweeteners such as stevia to help with that as well. We can formulate sublingual troches as well as transdermal gels, and even some pellets to help with those individuals who have been found to be using alcohol to help associate their and self-medicate their pain and inflammation. So we also use pellets in that situation. It can also be used in a transdermal gel in children, because sometimes children have pain as well. We do see with a transdermal gel that the onset of action is about 2.75 hours after the application. When we're using capsules, liquid, sublingual troches, we can formulate that in anywhere from 1 microgram up to about 6 to 9 micrograms. And we use that for inflammation, depression, autoimmune, GI issues such as Crohn's, ulcerative colitis, SIBO, but also a wide variety of dermatology applications. There's a lot of pain associated with dermatological situations, even eczema or Hailey-Hailey disease, bulbous pemphigoid, and even some lichen sclerosis issues. Again, we can use oral forms of low-dose naltrexone to get at the root, to affect the microglia, to affect the cell receptors, and to allow the mitochondria to work much more effectively. When we're using naltrexone in a 50 to 300 milligram, that is in a traditional dose, usually with a traditional tablet, and that's usually used for alcohol overuse syndrome or even methadone or opiate issues. We usually use low-dose naltrexone once a day, but we can use it anywhere from 2 to 4 times a day. Again, having to keep in mind the very specific rationale as to why we're using low-dose naltrexone. If we use it more than once a day, we see that the receptor sites become saturated and we lose the endorphin production, we lose some of the anti-inflammatory reduction, and we lose some of the autoimmune enhancing properties. But we do see that the mu, kappa, and delta receptors, the opiate receptors, are blocked a little bit more efficiently. And so if we're dealing just with pain, then we can use low dose or very low dose naltrexone multiple times during the day. As far as side effects, sometimes vivid dreams are reported, and that's actually telling us that low-dose naltrexone is working because it will drop someone into REM sleep. And a lot of times when people are using medications or even experiencing chronic pain or acute pain, they don't dream. And so when they start dreaming again, that can be rather scary sometimes. If we're using this because someone also has pain associated with mental health issues, such as post-traumatic stress disorders, then we need to be very careful about those vivid dreams, because sometimes those dreams are a little too much to handle and can trigger other physiological and mental conditions. If someone is experiencing insomnia, then we literally move the dose to the morning. We still see that upregulation of the endorphins by moving the dose to the morning, and it can still happen over 8 to 12 hours. But most of the science has shown that when the doses are given at bedtime, we see better patient outcomes. So what I love about low dose naltrexone is that, it just doesn't have a lot of side effects. It doesn't have a lot of drug interactions. So a lot of times what I tell providers is that, our first oath is to do no harm, but we really don't have much to lose by starting with LDN. Low dose naltrexone has minimal to almost zero side effects. There's very, very few drug interactions. It's just really low risk. And the beauty of it is that if we don't find someone's happy dose within 9 weeks or even up to 4 months, we literally stop. We give them a washout period and we start all over at the bottom, and sometimes even lower dosing, maybe going down to 0.1 or 0.25 milligram. And then we slowly increase over time again. And what we find is that we capture about another 50% of patients with a wide variety of inflammation and pain disorder, and they all of a sudden are finding better relief. They may even report that they have better energy, that they have less depression and less fatigue. And that can sometimes be very helpful when someone has been navigating their issues for years, if not decades, using multiple medications and still not finding much relief, that sometimes low-dose naltrexone can be that very specific door that opens and finds them a better road to health. We usually will see resolution of a wide variety of side effects within 7 days. So let's talk about some other compounded medication options. So here are some examples of some lollipops, even a wide variety of capsules, creams, troches, nasal sprays, and the colorant in the capsule is primarily for visual effect there. When we're talking about transdermal creams and gels, so these are very specific bases that are designed to help handle one active ingredient up to 4 or 5 active ingredients, but no more than about 30% of its total volume. So, and we'll get into that a little bit more. The base can be changed depending on where we're actually applying the cream or gel. So if someone is experiencing low back pain, we can actually apply the gel right to that dermatome. If they are finding that they have pain in their foot, we can not only apply that cream directly to that site, but then follow it up to the dermatome as well and apply it there, because that's where the nerve leaves the spinal column, and perhaps there's inflammation there as well. A lot of times we can design these transdermal products to be multifactorial. In other words, we can add anti-inflammatories along with antispasmodics, along with analgesics, and they can be tailored to meet the individual's needs. They're usually applied anywhere from 1 to 4 times a day, and they can be an adjunct to traditional therapies as well. So for example, here's some dermatome associated with the actual spinal column. And whether we're trying to reduce inflammation using anti-inflammatories or decrease nerve spasms, we're using antispasmodics, or to help with neuronal pain, we can use medications designed specifically for that. And the pharmacist can be very helpful here in determining exactly what is going to work as far as the products, but also the strengths of the products, and then what bases should be used as well. So here's some suggestions, a few medications that are commonly used in transdermal creams and gels. So gabapentin will help with nerve pain as well as analgesia, and it's used anywhere from 4 to 8%. Amitriptyline, again, used for nerve pain, 2 to 4%. Baclofin's a great great medication for spasm, anywhere from 1 to 3%. Cyclobenzaprine, again, for spasm, 2 to 10%. Amantadine works as an NMDA receptor antagonist, just like ketamine, and we could use one or the other. So if your medical license doesn't allow you to use controlled substances, we do have alternatives to those. And then when we look at nonsteroidal anti-inflammatories, ketoprofen, piroxicam, ibuprofen, there's a wide variety of other anti-inflammatories that we can put in there as well. We are always careful to make sure that we're not exceeding the maximum amount of molecular weight of the drug so that we're not going to cause the medication to fall apart, the final preparation fall apart, and then the patient doesn't call back and complain, well, it's kind of sticky and watery and it's just kind of a mess now. And sometimes active ingredients have a smell. Some of them smell a little bit fishy or smell a little bit musty, and we can use fragrances actually to help decrease that. Some of the fragrances have anti-inflammatory properties as well, so they can be very helpful in more than one way. We usually dispense these creams and gels in either jars, tubes, or meter dose pumps. And those pumps can be very helpful because you literally depress the top and a little bit squirts out, and then that can be applied directly to the affected area. When we're looking at ketamine, so ketamine's a medication that has been, we've gotten a lot of questions about ketamine, and it's a medication that's been around for a long time, and it was developed back in the 60s, mainly as an anesthetic. But we also know that ketamine can be used in psychiatry and pain management, as well as other issues as well. It has agonist effects as well as antagonist effects. It does cross the blood-brain barrier. And the S-enantiomer, which is commercially available in a nasal spray, is twice as potent as the racemic mixture of ketamine and is 4 times as potent as the R-enantiomer. But the R-enantiomer is not commercially available. When we compound, we're primarily using the racemic ketamine active ingredient. So what we do is if someone is currently using the commercially available product, we can usually we have to manipulate the dose with the racemic active ingredient. Analgesic doses are usually much less than the anesthesia doses, and there are some anti-inflammatory properties associated with ketamine and its metabolites. But the bioavailability of ketamine is very different when we're using different forms. So an IV mixture, an IV infusion, we're going to see much greater bioavailability, a quicker onset, and a much quicker peak plasma concentration. Whereas intranasal spray, we're only going to see about a 45% bioavailability, and the onset of action is within 5 to 10 minutes, and it's going to hang around for about 10 to 15 minutes. When we move into the sublingual and the oral dosage forms, we're going to see a much greater reduction of bioavailability. So what that means is that 10 milligrams of a nasal spray is not going to be equal to 10 milligrams of an oral capsule or even a sublingual drop. And a 10 milligram dose of IV is going to produce a much quicker and much greater response. So we have to keep that in mind, because as compounding pharmacists, this is our job to make sure that we are providing great information to providers so that when the provider is selecting a product for that patient in front of them, that they can be coached on what exactly is going to be the best dosage form for the lifestyle of that individual. Not everybody can come in for IV infusions whenever they come up with a migraine or they've got chronic pain. What we do know is that sometimes an IV dose of ketamine can last for days, where it literally will hit the pain goes away, and it doesn't come back for quite some time, sometimes even up to a month. Whereas intranasal ketamine can be used a little more frequently, maybe even every day for a few days before we see either side effects or some of the unwanted issues associated with ketamine. So ketamine can cause some dysphoria. So people literally can see things creepy, crawly. They can be dissociative. So they literally think they're in a different space. And ketamine can increase blood pressure and also temperature of the body. So we have to be very, very careful. And there's a wide variety of drug interactions, but there is not a drug interaction with low-dose naltrexone. So we do see sometimes LDN in ultra low doses and ketamine being used as a nasal spray to really go after some of that acute pain associated with like migraine or refractory migraines. That's actually quite common, even with PTSD. So sometimes when our warriors come back from the battlegrounds and they have significant injuries, a lot of times we're using a combination of products that are compounded so that we can really treat that individual, that hero in front of us, and produce better quality of life. So now I want to talk about a very interesting product. So this is a compounded medication. It is a medication that is usually combined with methcobalamin, and I'll explain why in just a moment. But it is manufactured from an Asian ginseng along with nicotinamide ribose. So it's a combination product. It is usually used in a nasal spray. It can be used as a sublingual drop, and it can be used anywhere from 2 to 3 times a day. It helps to decrease inflammation in the brain, which can then reduce inflammation elsewhere and also decrease pain sensitivity. It also can help decrease what a lot of people will summarize as executive burnout. So the mental health issues associated with chronic pain can be helped by using synapsin. It also has very potent neuroprotective activity. So looking at exactly how does it work? So it is reduces toxicity. It also reduces oxidative stress and improves neuroinflammation outcomes. So it attenuates the NMDA receptor and then changes the currents by which pain is associated across the cell membrane. So this one works specifically on the calcium channels, whereas ketamine can actually work more on the potassium and sodium, but also the calcium channels. And here is the science behind that. So looking again at more nasal sprays, we look at oxytocin. So there's quite a bit of science of using oxytocin in depression, but also some pain situations as well. So specifically with fibromyalgia, we usually use that in a nasal spray because oxytocin is very sensitive to heat. So if we're using it in a sublingual troche, we've got to make sure that that base is not very warm before we add the oxytocin active ingredient so that it doesn't destroy it. And oxytocin is not active orally. It does help lower cortisol levels. So again, it can help reduce that inflammation. It can reduce situations associated with glucose, and which can increase inflammation. It also increases or changes the cortisol to DHEA ratio. And the reason for that is because when you have low DHEA, which is quite common when there's a hormone imbalance, we see a blunted effect or a lesser effect of overall sense of well-being. And that often happens with chronic pain. So when you have a lower affect, a lower mood, and we give a small amounts of DHEA. So for women, we're looking at maybe 5 or 10 milligrams, and for men, 25 to 50 milligrams. We can use that in conjunction with oxytocin and help to build that connectivity between brain and body. And it can also help calm the tissue, maintain better muscle contactivity, and it can help reduce pain because it helps to release endorphins. So these are medications that can be used together or as monotherapies. Some people will want to try one at a time because of price, or because a lot of these are nasal sprays. Putting a whole lot of stuff up your nose isn't necessarily as fun and easy to do. But we can use oxytocin once a day or up to 4 times a day. And a lot of times when people are using medications for nerve pain, for depression associated with chronic inflammation and chronic pain, a lot of times those antidepressants can actually lower libido. And if you're in chronic pain, if you're feeling pain all the time, you probably just don't have a lot of sexual desire. And oxytocin a lot of times can help with that connection back to your partner. So this is how you can also find more information about low-dose naltrexone. You can find me at the LDN Pharmacist. And there are some veterinary applications of low-dose naltrexone as well, especially for tumor growth and for pain. This is my personal email and my personal phone, and I hope that you reach out and connect with me, as well as my affiliated network of pharmacies. I want to thank you for joining me today. And if you have any questions at all, please feel free to reach out. I'm more than happy to answer your questions. And thank you again. Have a wonderful day.